with that, I'm handing it over to Alex.
Thank you so much. Welcome, everyone, and thank you for being here this morning. It is my honor to introduce Dr. Pratik Sinha, Assistant Professor in the Department of Anesthesiology at Washington University School of Medicine in St. Louis. Dr. Sinha's groundbreaking research applies state-of-the-art data science methods to clinical and biological data to better understand the heterogeneity in critical care syndromes such as ARDS and sepsis. His work is moving the field closer to truly personalized care and improved patient outcomes. He has practiced clinical medicine on 3 continents and authored more than 100 peer-reviewed publications. During the COVID-19 pandemic, Dr. Sinha worked tirelessly both in the ICU and in his research lab, earning the COVID-19 Exceptional and Exemplary Duties Coveted Award, as well as the 2023 Dean's Impact Award in recognition of his life-saving contributions. Beyond his research in clinical care, he serves on the editorial board of the American Journal of Respiratory and Critical Care Medicine and mentors clinicians and data scientists alike, including myself. In addition to his professional accomplishments, Dr. Sinha has a kind heart and a great sense of humor. Please join me in welcoming Dr. Sinha for his talk entitled Molecular Phenotypes of Critical Illness, Moving Beyond Syndromes.
Can everyone hear me? Yeah, it's so nice to be here. And it's so nice to see so many people in person. I'm slightly suspicious you're not here for me, but for the art. And I definitely don't blame you because it does look amazing. It's really a pleasure to be here. I have many close ties to Alex and Matt Chirpek and others that are in the Department of Medicine. So it's really great to be here and talk about some of the work that I'm doing. These are my conflicts of interest. I'm just going to point you out to Prognosis Inc. Because I'm an advisor for that company, but I'm also going to show you some data later on that has emerged from that company. So I just want to make it clear that I sit as an advisor on there. Just sort of, this is my funding source, and I want to take a moment to pause and acknowledge what great work the NIH and federal funding does for advancing science. Not just myself, but I would say that their funding has changed the way we practice medicine, particularly in the fields of oncology and others. And it's really important for me as a scientist to just pause and acknowledge how much it's contributed as an immigrant for me to be here and practice my science. Okie dokie, so these are the learning objectives. I will pause for you to look at it, and then I will tell you what the overview of my talk is. So first, I'm going to start talking about what the problem is. I'm just going to give that away. The problems are syndromes that we use in the ICU, sepsis, ARDS. All of those, to me, are very problematic. And then I'm going to talk to you about a solution. Another disclosure here, because of time, I'm more or less focusing the solutions to these phenotypes, to the work that have emerged from our group. But there are many other people out there who are doing amazing work that I don't have the time to go through. Then I'm going to talk about implementing these phenotypes. How do you identify these phenotypes at the bedside? And the idea is, how do you take these complex, multivariate biological signatures and try and identify these patients at the bedside? Then I'm going to talk a little bit about what we know about the phenotypes from a biological standpoint, and then the future, and that's mostly just me musing about stuff, so that should be fairly fun. Okay, so what is the problem? We start by asking the question, what is ARDS? I'm married to a person who is not a physician, and about 20 years ago when we got together, she asked me, hey, what do you study? And I remember just waffling on about this thing called ARDS, and she said, I don't really understand what it is. And 20 years later, I still don't have an answer for her. ARDS means many things to many people. Let's start by what it means to us now. I'm going by the Berlin definition. There's an even newer definition. So I know not all of you practice critical care. These sets of symptoms, a PF ratio, PaO2, FiO2 ratio less than 300, onset of symptoms within 7 days, bilateral opacities and chest radiograph, which this is a gimme. This is what a great ARDS X-ray looks like, but most of them don't actually look like that. And somebody who's on a ventilator with a PEPA 5. These set of symptoms are frequently encountered in patients with that are mechanically ventilated, particularly as time passes after a day or two. If you've got pneumonia, these symptoms are really frequently encountered, but it's not clear whether the patients have the syndrome that we seek to find. I'm just going to point you to the fact that there is no link to etiology. And it stands to reason, at least in my mind, that if you're trying to intervene biologically, there has to be some linkage to biology. And the fact that we have disconnected our syndromes to symptomatology, limited it to symptomatology and kept it abstracted from underlying disease process is inherently problematic. And the problem has been compounded by the fact that we've spent a lot of time, energy, studying ARDS, some really important studies here. This helpful timeline by Art Slutsky and colleagues was showing both what we've done at the bedside and at the bench. Arguably, I would say that two of the most important things that have maybe sent us chasing our own tails has been the introduction of what I call the epidemiological definitions of ARDS. So through the 70s and 80s, the way we practice and research medicine changed, and the notion of doing these big trials that were focused on answering a single question became quite important as methodology, almost the reference standard when it comes to trying to discover new knowledge. And in order to facilitate that, our field sort of introduced these really broad clinical criteria for what ARDS is. Subsequently, the Berlin definition has been an iteration of it, but that also has remained equally broad. And I would argue the newest definition that we've introduced, which is called the global definition, compounds this problem even further. And really what the problem to my mind is that there's been a growing dichotomy between what we understand as the biological phenomena of what ARDS is. This is a helpful cartoon by Taylor Thompson and colleagues, where all of these things, I think, are correct and true and biologically sound. I think that the idea that you get cellular infiltrates that cause damage, leading to epithelial damage, endothelial damage, which we microscopically are supposed to pick up through X-rays because you get the flooding of the interstitium and the alveolar space, and that microscopically these signaling molecules are what are driving the injury that we see. All of these things are true. But what we are saying to ourselves when we transition into a clinical trial phase is that we can capture all of this biology faithfully using these sets of symptoms. And whilst I think it probably captures some of this, I think it captures a whole lot more that's unrelated, and therein lies the problem. I can see Dr. Chirpek is sitting in the audience, and he must be thinking, what about sepsis, Pratik? That sounds pretty cool, very biological. Well, I'll tell him, yes, we do understand a lot about the biology of sepsis. We know that there are mediating molecules, sort of pathogen-associated molecular patterns that instigate cellular signaling, and this has been charted really well. And we also know that it's highly dynamic, that sepsis is not something that you meet at a cross-sectional point and it stays the same. We know that it changes over time. So we have all this deep biology. Some of it has even got Nobel Prizes for understanding how pathogens interact with the host. We know it's dynamic. And when it comes to how we capture this clinically, I would argue it's even worse. The sepsis 3 definition, in the absence of knowing what a patient's underlying SOFA score is, says that if you have a SOFA score greater or equal to 2 and you're suspected infection, by definition, you have sepsis. And you may ask, how does this show up? And this is one of my favorite studies. This is Forner and colleagues from Vinnie Liu's lab in Kaiser Permanente. They looked at how, in 30,000 patients, how does people who meet the sepsis criteria, how do they show up in the EHR? These are the topics most associated with that define each individual. Each strand that you see is one patient. And I can save you some reading by telling you this is a hot mess. And then, broadly speaking, this is probably how we think about capturing patients when we do clinical trials in sepsis. And one of the problems that comes here is that we don't really know what sepsis is. Therefore, we find it really difficult to define how people with sepsis are going to fare when it comes to outcomes. In the blue triangles are what was predicted by the investigators to be what their outcome would be. The control group mortality is actually what you see in the black dots there. And you can see that rarely do we hit the target. So if you can't tell who your patients are, how they're going to do, it becomes really difficult to tell whether or not a treatment is going to work because you can't predict outcomes. And you might say, why is this heterogeneity a problem? Well, here's a list of trials that have tested biological therapies in ARDS. And here is another list of trials that have tested biological therapies in sepsis. And once again, I'm going to save you some reading by telling you all of these are negative. These aren't my words. These are words from some eminent intensivists who, in several articles, called sepsis and ARDS graveyards for pharmacotherapies. And this is not a problem just for people like me who study these syndromes, sorry. So easy to make that mistake. It's not just a problem for me, but it's really a problem for our patients. Because when it comes to investing in new therapies, if we're not having support from pharma who think that this is a race not worth running, it becomes really, really problematic to advance science in a way that helps our patients. So we're looking for a solution. I come from Liverpool, and hello to all Liverpool supporters out there. This is John Lennon, who says there are no problems, only solutions. Lennon also said that time you enjoy wasting is not time wasted. So let me show you what I've been wasting my time on. So the concept is that we try and identify underlying biological subgroups that are more homogeneous and have similar biological characteristics in the way that you have a biological test that you can capture these patients, and the long-term target being that if you see a heterogeneous population up there, that you find a multivariate solution, so not just a single variable. Subgroup analyses have been around for a while. Our thinking is that because this is a systems biology problem, and it's a dynamic problem, that you need multiple variables to capture these underlying phenotypes. And when you do, you try and match therapies to these patients. Ideally, the end game being that when each person comes into the ICU, we have enough information about the characteristics and the signatures, and hopefully their trajectories, that we can say, this is the therapy that we need for this patient at this time. And this is not a new idea. I was delighted to find this paper by all our mentors. This is Hippocrates, who several thousand years ago almost sort of figured out the mantra for my lab, which is that medicine is not absolute. Its directions cannot be generalized to everybody. Each human body organism is different and responds differently to therapy. Therefore, the same treatment cannot be used for everybody, and that physicians should choose appropriate treatment depending on patients' individual characteristics, such as different health status. And I would argue that every intensivist that is in this room right now or on Zoom, we all practice as such. But when it comes to knowledge gathering, we seem to lose the idea that we do actually treat our patients as an individual. And so really, a lot of this work is about sort of bringing our knowledge gathering closer to our knowledge implementation. And two of the ideas that we use, one of them is prognostic enrichment. So you try and identify patients in whom the outcome of interest is more likely to be identified. So for example, in ARDS, people who have more oxygenation problems, you coalesce them together because they're more likely to do worse, have prolonged ventilation, or mortality is higher. But really, the interesting part of the game is predictive enrichment, or what we call identifying endotypes, where the identifying features of the phenotype are likely to be targeted with therapies and improve outcome. Of course, cancer, we see this done very successfully and has been the inspiration for a lot of the work that we're doing, but they have it easy. Did I say that loud? Because they have time. Unfortunately, in critical care, our patients transition very quickly from these states. So it makes it much more challenging to capture phenotypes, underlying biological characteristics faithfully. So the work I'm about to show you was pioneered by Dr. Carolyn Calfee at UCSF. She did the initial work. The idea was that you use unsupervised approaches, i.e. you let the data do the talking. Specifically, we used a form of modeling called latent class analysis. I'll be happy to speak to people afterwards if you're interested in the methodology of how we do it. The idea is that we throw in a bunch of baseline clinical characteristics, such as protein biomarkers, clinical data, to get a multivariate solution. We throw it in, we apply modeling to this data and see what underlying structures exist and whether or not there are discrete subgroups that the models can identify. And it's important that if you do identify phenotypes, that they are useful. They should be robust, reproducible, and generalizable. And I hope I can show you some of those things in the following slides. And then there's the question of how do you take this complex model and apply it to the bedside. So across many cohorts, we have identified what we call two phenotypes or two molecular phenotypes called the hypo and hyperinflammatory. Represented here in the red line is a hyperinflammatory phenotype. And what you see on the x-axis are the continuous variables that went into the model. On the y-axis is the mean standardized values of those variables. So 0 is what the population mean is for a given variable. Say, for example, IL-8 at the bottom left. The 0 is the mean. 1 is 1 standard deviation greater, and -1 is 1 standard deviation less. We called it the hyperinflammatory phenotype because it was associated with increased pro-inflammatory cytokines and more organ failure, as opposed to lower values of protein C, more acidosis, and lower blood pressure. And accordingly, there was more vasopressor use in that group too. About 30% of the patients are hyperinflammatory. And in terms of generalizability and reproducibility, we have shown this in multiple cohorts, independently in multiple cohorts of ARDS, both RCTs, observational cohorts, invalid and early. And at the bottom, these are all cohorts of pediatric cases of ARDS. So we have found the same two phenotypes that conserve across multiple populations, including in children, and that mortality, as you can see in red, is consistently and significantly higher compared to the hypoinflammatory. The reason why the field is interested in this is because across secondary analyses of multiple trials, we've identified differential treatment responses. This is true in PEEP, in the alveoli trial, fluid management strategies in the FACT trial. These are all NHLBI network trials that were done. We also observed that simvastatin showed a survival benefit in the hyperinflammatory phenotype compared to placebo in the hyperinflammatory phenotype, but not in the hypo. And it's important to reiterate that all of these trials, as you would have guessed, have all been negative when the original studies were done, and that when we used other metrics of disease severity, we did not observe the same differences. So you have just heard me say that ARDS might not be a thing. So it's worth asking the question then, are these really phenotypes of ARDS? So we then asked the question, well, if we're syndrome agnostic, what if we took other syndromes, such as sepsis, and see whether these phenotypes exist? Well, lucky for us, they did. We recapitulated the same approach, same biomarkers that you see at the bottom on the x-axis there, but these were in populations of patients with sepsis and critical illness. And again, we found the same two hypo and hyperinflammatory phenotype. And we repeated this in another cohort. And then what we did was we took models that we had developed to predict the hyperinflammatory phenotype in ARDS and pointed it at these phenotypes that we saw in sepsis and found that there was huge overlap with area under the receiver operator characteristics of 0.93 to 0.96, suggesting that there was good overlap between the sepsis phenotypes that we've identified and those that we identified in ARDS. And now we've found these in approximately 7,000 patients using biological measurements in multiple cohorts of sepsis. So I hope I've convinced you that this is reproducible, it's generalizable, and syndrome agnostic. Just to give you an idea, this is work by Beth Gay, who is a fellow at UCSF. And she applied these methodologies to the Clovis trial and found that, again, there were two phenotypes, similar to the hyper and hypoinflammatory. But I just wanted to point your attention to the fact that the Clovis was done, this was the only cohort that we interrogated from the emergency department. This was very, very early on in the course of septic shock. And the samples were acquired within an hour of their diagnosis of sepsis and septic shock. And it was all in the emergency department. Almost half the population who are hyperinflammatory had positive blood cultures, and more on that later. But more importantly, the prevalence of ARDS was extremely low in this population, only 3 to 4%, suggesting that in patients with just sepsis, that these phenotypes were strongly identified, and that really you didn't need ARDS to fall into this molecular phenotyping paradigm. So the next problem that we faced was that these models, these latent class analysis models, they're comprised of 30 or 40 variables, they're complex, and they're quite impractical to apply prospectively. So the problem we faced was, how do we take these multivariate models and try and identify these patients in real time at the bedside? The motivation for that is, of course, that we want to start testing therapies in the hyper and potentially the hypo-inflammatory phenotype. So we took two strategies as you're looking at it to your left. The first was that we just reduced the number of features or the number of variables. So we reduced it from 30 or 40 down to 3 or 4. But in that, these parsimonious models that we built, we still contained protein biomarkers. And that is problematic because we don't have a point of care test for those. So the other strategy that we took was to get rid of all the protein biomarkers and use supervised machine learning models that just comprise of clinically readily available data and train the models to predict the phenotype that way. And I'm going to show you data pertaining to each of those. First, these parsimonious models, I gave you a glimpse of it already before, but we reduced it. We used a lot of machine learning methods to try and identify the best variables that can predict these phenotypes. And we identified IL-A to bicarbonate protein C. And from the AUCs, you can see that they were very good at predicting the phenotype. The hyperinflammatory phenotype. We also described a bunch of different permutations that were high performing with reasonable AUCs across each of those. And the motivation for doing that was because at the time that we published this paper, we didn't know which biomarkers would be the first ones that get translated to the bedside. The technology exists, but we just haven't convinced enough people that it's worth investing to measure these proteins rapidly at the bedside. So we described permutations of these models. And just as a sort of a sanity check, we took this parsimonious model and pointed it to the trial that tested simvastatin versus placebo. Using this parsimonious model, we again found that there was a significant difference in outcomes in the hyperinflammatory phenotype with simvastatin therapy. Because really, this is what we want to capture going forward into the trial. Maybe not the prognostication part of it, but certainly the treatment response is what we're really interested in doing. And as a small proof of concept in a sub-study of the FIND trial, which I'm going to show you some unpublished data at the end. This was done with Thomas Zakameni, who's a professor in the UK, and Danny McCauley, who's also a professor in the UK in Belfast. In 39 patients in 2 centers in the UK, we used the parsimonious model comprising of IL-6, soluble TNFR receptor 1, and bicarbonate. This was in patients with COVID-19. We used a novel point-of-care multiplexed assay to quantify IL-6 and soluble TNFR1 in real time. And we were able to classify patients into the hypo and hyperinflammatory phenotype using this technology and the parsimonious model. This needs proper validation. I'm happy to share some data with you towards the end. So this is one way that we have proposed that we can identify these patients at the bedside, using a point-of-care multiplex assay to identify these 2 proteins and then put that data into a smaller model to predict the phenotypes. But the protein biomarker issue is still a problem. First of all, this state-of-the-art multiplex machine, it costs about $40,000. Each sample will probably cost hundreds of dollars. It makes it inequitable to be able to distribute this across multiple centers and also across the globe. So we wanted to find a way to get rid of the protein biomarkers. And then, I apologize, I couldn't find a bigger picture. And I mean, I just want to it's very easy to stare at the actor like good looks of Dr. Chirpek here. But please do look at that desk. No work is being done there, let me tell you. It's a good job that I know he's one of the most productive scientists that I know. But anyway, this work was done in conjunction with Dr. Chirpek. And really what we did was we took just vital signs and lab values and put it in and used these variables to train a supervised model. We used an algorithm called XGBoost to try and identify the phenotypes. And we trained it across 3 randomized controlled trials and tested it in a holdout trial. And these models work very well with AUCs of 0.93 to 0.95. Again, as a sanity check, this is the alveoli trial, where I'd previously shown you that we observed differential treatment response with PEEP strategies in mechanical ventilated patients, the overall mortality in black was 45% in the hyperinflammatory compared to 20% in the hypoinflammatory. With high PEEP, there was a treatment benefit in the hyperinflammatory phenotype, but the direction was opposite in the hypo. And this was only using vital signs and lab values. So there were no protein biomarkers. And as you can see, this recapitulated relatively faithfully with the bigger, complex latent class analysis model that had all the protein biomarkers. So we found these findings quite encouraging. And subsequently, this is Manoj Madali, who's faculty now in Atlanta. He's also a pulmonologist and intensivist. We wanted to see whether these models, these clinical models, only vital signs in labs, whether they generalize more in observational cohorts, and whether you can take data out of the EHR, plug it into these models, and predict the hypo and hyper. We also looked at the LungSafe observational study, which is the largest ARDS trial of its kind, and pointed the model, there were no biomarkers here, to see the prognostic value of this schema in this large observational cohort. And this was across the globe because up until now, we had only used this in the US and the UK. So we wanted to see whether globally this worked out or not. Again, in these observational cohorts, this clinical data, just using the clinical data from the EHR, it performed quite well with AUCs of 0.91 and 0.93. And importantly, the EHR data derived phenotypes captured the biology because you can see here IL-6 and IL-8 in each of these cohorts was significantly higher by orders of magnitude in the hyperinflammatory compared to the hypoinflammatory phenotype. And in LungSafe, we also found that mortality was 60% in the hypo compared to the hypoinflammatory phenotype. And then we did a target trial emulation where we looked at the interaction of PEEP strategies in LungSafe and found, like alveoli, that with high PEEP, there was a survival advantage in the hyperinflammatory phenotype, but not in the hypoinflammatory phenotype. So the next question, this was work by Georgios Kitsos and colleagues from Pittsburgh, where they asked the question, can clinicians, given all the information, not the protein biomarkers, but given all the clinical data, can they identify the hypo and hyperinflammatory phenotype? It escapes me, but I think there were at least 30 or more board-certified intensivists who had quite a lot, at least 10 years of experience. They were given patient data from the EHR at the time when they did their phenotyping to see, can they identify the hypo and hyperinflammatory phenotype? And I'm just going to point your attention to the positive predictive value for identifying the hyperinflammatory phenotype was 0.33. It was worse than a coin toss. The problem is that they kept identifying people who would do badly, who had more organ failure. And the point is that the phenotyping strategy doesn't just capture organ failure. Clearly, if you're hyperinflammatory, organ failure metrics are higher, but it is not synonymous. The two aren't synonymous. So what do we know about these phenotypes? First of all, we know that these phenotypes are highly dynamic. What you can see over here is at day 0, there is about a 70-30 split, the orange being the hyperinflammatory, the blue being hypoinflammatory. By day 2, only half the patients that were hyperinflammatory were hyperinflammatory at day 2. They either died or they changed back to hypoinflammatory. And by day 4, there were only about 5% of the patients that were hyperinflammatory. So these transitions happen, and we've only studied them over 48-hour periods, but we know that they halve in 48 period time. This is alveoli. Again, similar thing at day 3. Only about 30% of the patients that were hyperinflammatory at day 0 were hyperinflammatory at day 3. And this is true in Clovers, which is a sepsis trial, septic shock trial, very early in the emergency department, where the transition from hyperinflammatory to hypoinflammatory was much greater. And I suspect these two trials were in the ICU, where patients that were captured in the phenotyping schema already had considerable organ failure. So the transition across phenotypes was much lower. What's important is that how you transition has important prognostic value. The dark blue that you see are patients that were hypo to start with and stayed hypo. The light blue are those who went from hyper to hypo. And the orange are people who were hypo and then went to hyper. And the patients that stayed hyper over time are the ones at the bottom in the red, and they do the worst. And this was, again, true in alveoli, where if you stayed hyper, you did really badly. But if you went from hyper to hypo, which is the light blue, your outcomes were actually quite good, suggesting that transitioning out of this phenotype is how quickly you do it seems to be important. Even more so in clovers, that people who are hyper, who transition to hypo by day 2 or 3, their mortality was as good as if you were hypo to start with. So these findings suggest that how long you spend in the state is important. This is work by Sinha Tripathi, who's a scientist in my lab. And she examined the association of baseline hyperinflammatory phenotype with outcome. And to cut a long story short, and I'm going to run through 3 slides because I'm mindful of time, is that by day 5, the association, if you die after day 5, the association of your baseline hyperinflammatory phenotype with death disappears. That actually it only predicts deaths that happen in the first 5 days. And from the survival curves that I showed you previously, you can see that the mortality separates out very quickly. And 80% of the patients who are hyperinflammatory that die within the first 7 days. So really, this phenotype is capturing a phenotype of disease severity that leads to early mortality. And the association with deaths that happen later of baseline phenotyping is relatively low. And this was true in the Mars cohort of patients with septic shock, and also in early, which is a sepsis cohort from UCSF of critically ill patients. So again, this is work by Dr. Madali, where we asked, what are the predictors of outcome in, these are in 2 separate cohorts, in the hypoinflammatory phenotype. In the hypoinflammatory phenotype, the only 2 predictors of cohort that were consistent across, predictors of outcome, sorry, in the hypoinflammatory phenotype across both cohorts were age, and you can see there's a significant difference between survivors and non-survivors in the hypoinflammatory phenotype, and temperature, where lower temperature was associated with worse outcomes in the hypoinflammatory phenotype. Whereas in the hyperinflammatory phenotype, the 2 consistent findings across both cohorts were that IL-8 was associated with outcomes in the hyperinflammatory phenotype. You can see it was higher in those patients died compared to those who survived. And again, temperature features here, where lower temperature was associated with worse outcomes. And the takeaway from this is that the features that sort of predict the phenotype within the hyperinflammatory phenotype also seems to be associated with death, suggesting that its inherent features may be capturing the associations with mortality, whereas in the hypoinflammatory phenotype, those predictors were less obvious. Broadening this out across a bunch of proteins, I know this is a very, very busy slide, but these are just cubic splines. On the x-axis is going from left to right, the values of these proteins get higher, and as the tangent goes upwards, it means those values are higher in people that die. This is just presenting all the data. And really, the takeaway that I want to show you from this is that look at the blue lines here, they're kind of underwhelming, but if we look at these same proteins and its association with death in the hyperinflammatory phenotype, there's a lot more action. You can see that not only are there linear associations, but there are actually some non-linear associations. And one of the problems that we have by amalgamating syndromes, where previously all the data that you have seen about these proteins have been across both of these populations, there is a blunting of signal, and that we're leaving so much good information on the table about the association of these circulating proteins with death in our patients, that actually taking these paradigms for knowledge gathering may also be important. And this is a slide that, this is a slide that I have a lot of fun looking at, and we did a Bayesian network analysis. This sounds very complicated, but I'm just going to try and simplify it for you. These are, what we did here was we looked at how do these proteins interact with one another? How do they correlate with each other in survivors as you look to your left and non-survivors as you look to your right. And I'm just going to point to you that in non-survivors, these proteins which we've grouped together, say, for example, up there, which are pro-inflammatory cytokines. In the blue, these are epithelial or organ-specific cytokines. And then in the green, you have so coagulopathy and endothelial dysfunction cytokines are in pink. They are all correlated with one another, but not across these protein domains. Whereas in survivors, what you can see is that there is good linkage between inflammatory proteins and endothelial proteins, anti-inflammatory proteins, and proteins of coagulopathy. So the network is much stronger, and that there are complex interactions that occur that are informative of survivorship. That I think these are new things that our lab is hoping to study in the future to look at protein-protein interaction and its association with survival. Okay, so a good question to ask at this point is we've sort of gone from ARDS into sepsis. We know that they're dynamic, but what is driving these proteins? Well, we think at this point that it's infection. We saw that I've showed you in Clover's 50% of the patients were bacteremic. In these sepsis cohorts, we observed 30% of the patients were bacteremic in the hyperinflammatory phenotype compared to 16 in the hypo, and that there was a predominance in the red and pink of gram-negative bacteria. This was true in early. Again, you can see a stronger pink and red shading that comes across in the hyperinflammatory phenotype, whereas in the hypoinflammatory phenotype, not only was bacteremia lower at 10%, it was predominantly gram-positive species. And in this work by Lucille Nathan and colleagues, again, Lucille's a data scientist at UCSF, we observed that the total bacterial mass was much higher in the hyperinflammatory phenotype compared to the hypoinflammatory phenotype, and that there was a predominance of E. coli in these patients. And this is work in conjunction with Rishi Chandaraj and Bob Dixon, who are at the University of Michigan, where we looked at 2,000 patients with bacteremia and classified them into the hypo and hyperinflammatory phenotype. On the y-axis is your probability, a continuous probability of whether you are hyperinflammatory or not. 1 being really hyper, 0 being really hypo. I just want to point your attention to the fact that the patients who had E. coli bacteremia, the distribution of this continuous variable is bimodal. That actually these patients show up as either 1 or 0s. And there's very little distribution of patients at a probability of 0.5, which is what we use to split this patient. And this is not true when you look at Staph aureus, where most patients are mostly hypo. And this is true across other gram-positive organisms and gram-negative species. But if you take the continuous variable to be a metric of organ failure or disease severity of critical illness, like the Apache score, you can see the distribution is much more normal, where at the middle is the greatest distribution of patients, which is what you'd expect. Now, in these bacteremic patients, if your source was co-located to the abdomen, you were almost always hyper. If you were in the lungs, you had the same bimodal distribution that you observed previously. However, if it was other, which is skin and other issues, or urine, you have a much more normal distribution of hyperinflammatory probability. How quickly you become positive is also different between the hypo and hyper. This is proportions of cases on the y-axis and time to blood culture positivity. You can see it's much higher in the orange, which is the hyperinflammatory phenotype. There's a difference of 9 hours, suggesting that how much pathogen around is also important. We recapitulated these findings in mouse studies where we infiltrated inoculums of E. coli species. And as you can see here to your bottom right, as you increased more E. coli, when the order of magnitude increased of E. coli, that you got a much more spiked response of pro-inflammatory cytokines. So to cut a long story short, we may have rediscovered gram-negative septicemia. So if we have discovered gram-negative septicemia, we ask the question, does antibiosis make a difference? This is a trial of Euphrates trial that looked at polymyxin B, which scrubs endotoxin from patients. The original trial showed no difference between outcomes. This population was enriched for endotoxin they have an assay which they measured endotoxin. So only patients with very high endotoxin levels were allowed to enter this trial. Again, the distribution of hyperinflammatory phenotype was bimodal. You can see the lowest distribution being at 0.5, and we observed a significant treatment response where on the y-axis is mortality, on the x-axis is the probability of being hyperinflammatory, and if you're really, if you're really hyper, there was a difference between outcome, but if you were really hypo, polymyxin B, you did worse with it. The mortality went up. So this is the control arm you can see over here, and that introduction of the treatment modulated the association with outcome, but it was a worse association here in the hypo patients with an improved association in the hyper patients. We next asked whether or not there's a difference between activated protein C, and for those of you who are my vintage and older, we have all tried activated protein C, and our lived experience was you would give it to the patient 1 week, you'd be like, this is amazing, this drug really works, and you'd go home and tell everybody, oh, we found a great drug. Next week, you'd give it to somebody and you go, oh, I think I might have killed them. And then eventually this drug was initially FDA approved, then they asked them to do another trial, which was a power shock trial, and then the drug was withdrawn. So the power shock was 1,700 patients, activated protein C versus placebo, primary outcome is 28-day outcome. Again, like most of our trials, this is a familiar survival curve. And they did a bunch of subgroup analyses, including protein C levels and SOFA scores, organ failure. They tried a whole bunch of things. Nothing really showed out to be positive. But in the paradigm of these phenotypes, again, I'll walk you through this. On the x-axis, you have the probability. So these people are really hypo. These people are really hyper. This is 28-day mortality. This is the association of increasing probability and death in the control arm, the placebo arm. This was again modulated. And these are the patients that we probably gave activated protein C to, and they didn't do well because it did increase mortality. However, moving on to the hyperinflammatory phenotype, you can see that there's a survival benefit, albeit take it with a pinch of salt. These are all secondary analyses. And so you might remember that I told you about the disconnect between our knowledge gathering and knowledge implementation. Well, here's the two papers that the activated protein C cited when they came to making the discovery of where this works. And I'm pointing your attention to the fact that these are both studies that were done in baboons with E. coli. We gathered our knowledge in patients who had sepsis with E. coli, but made the assumption that all sepsis is the same when we gave it to people. And this is, to me at least, a lesson learned that we need to do better in terms of our knowledge implementation. So speaking of knowledge implementation, this is a study by Kiran Reddy from Danny McCauley's group, where this is unpublished data. The abstract was published in ATS this year, where they did large-scale validation of the parsimonious model with this point-of-care test for the biomarkers. We used IL-6, soluble TNFR1, and bicarb, and they tested it across 500 patients, and showed that inflammatory phenotypes can be identified prospectively at the bedside. And based on this technology, in the Panther Consortium, you can access the website over there, we are now planning to do prospective trials that's phenotype informed, where patients using the FIND framework will be stratified into hypo and hyper and entered into a platform trial where we're going to be testing people with therapies. I think the first two we're going to look at are simvastatin and baricitinib. And I think this is the future of the work that I'm showing you. But I'm going to give you a word of caution for the last 2 or 3 minutes. I'm just going to pause here. This is, I don't know, we've talked about that person there. And this is Alex Spicer, who's another one of my collaborators here who works in Matt's lab. And the word of caution here is that I think these responses are highly conserved and that it's really important. This is an ode to multivariate solutions to complex systems biology problem. It's Friday, I'm finishing up in time, so I'm gonna rush through things here, but this is one of the largest study of its kind, 3,800 patients in the emergency department with suspected infection. We used a 29, well, there were 43 biomarkers, which we reduced down to 29, and did some multivariate modeling and first found 2 groups. I'm gonna rush through this because it's less interesting. But the dysregulated group in red that you see over there, we did some more subclustering of it. This is on your bottom left. And we found some really interesting pattern. There was one phenotype that was associated with high thrombomodulin and tissue factor. I got very excited and thought, hey, this might be an endothelial forward phenotype. We found another one. This is actually quite interesting because this is patients that had high GM-CSF and IP10. And then we had we had one set of phenotype that had higher procalcitonin, CRP, which we thought obviously would be associated with infection. And then this phenotype emerged with high IL-6, high IL-1RA, TNF that looked very much like the hyperinflammatory phenotype. And looking at it, what we observed was that the predictor of the first cluster, which I thought initially was the endothelial cluster, actually co-located strongly with patients who had acute renal failure. So this cluster was associated with patients with high creatinine. Cluster 4 was associated with viral organisms, suggesting that the host response strongly co-locates, protein host response strongly co-locates with the type of pathogen that you have. This was associated with both gram-negative and gram-positive, but here, the cluster 6, which I told you that looked like the inflammatory phenotype, was associated with gram-negative bacteria, gram-negative organisms. Again, suggesting that these are highly conserved. But the problem with this was that the mortality, which I'd shown you in the hyperinflammatory phenotype, was sort of 30 to 60%, here is 5%. And what is even more alarming, I would say, is that if you look at the levels of IL-6 in cluster 6, it's about 1,000 here, hyperinflammatory, it's comparable, if not higher. Same with IL-8, it's comparable, if not higher. So what is it that's different about these? And sorry, I forgot to fill in one slide, but you'll have to believe me when I tell you this. The levels of Ang2 are by orders of magnitude higher in the hyperinflammatory, and it was about 20,000 in Clovers. And that it's a combination of inflammation, endothelial dysfunction, I think metabolic failure here with serum bicarbonate, which captures this phenotype. So this is just a tale of caution that using one or two variables to try and shortcut this process will probably take us back to where we started. So to summarize a decade's work in about 15,000 patients using biology, we've described two phenotypes called the hypo and hyper. If you were to include the clinical classifier that Matt helped us build, this is going, the data we have is now approaching close to 100,000 patients. About 30% are hyperinflammatory. They're associated with multivariate modeling that includes inflammation and endothelial dysfunction, more organ failure, more bacteremia with Enterobacter acei, we think is the principal driver of it, but not the only driver. And it's associated with differential treatment responses. In terms of future work, where is this signature coming from? We want to study the sites of origin of infection to see whether it's the immune system locally that's driving it. We want to also try and better understand what's specific about the pathogen. So the idea we're doing is to get clinical isolates of the pathogen and sequence it to see whether there's some virulence, genomic factors that are driving why people have this aberrant response, or whether actually it's host genomics that increases your susceptibility. We're thinking about other therapies that we can try in this paradigm. I do think activated protein C would be good, but I think the field has lost its appetite. And then also to look at functional immunology in terms of why hypo and hyper patients are different. So to summarize, I have shown you a hyperinflammatory phenotype, which is well characterized. It is a distinct host response. We think gram-negative bacteremia is what's driving it. I haven't shown you some of this data, but innate immune activation is the main feature of gene expression in the circulation with these patients, and it's associated with metabolic failure. We seem to think that our data, albeit secondary analysis, show that this phenotype is modifiable, and how quickly you change it is associated with outcomes, and that the hypoinflammatory phenotype, which I've barely spoken about because we know nothing about it and it's very poorly defined, but it comprises most of these patients. I have just been the voice that has brought you sort of decades worth of work from so many collaborators and so many people from my lab. But specifically, I want to thank the participants and their families from all of these trials and observational studies whose generosity I have leached off over the last 10 years or so. There are two people I have left off this thing. So with that, I thank you for your attention.
So thank you. I think we'll do a few questions and then we'll do our drawing. Okay. Well, I'm going to take chair prerogative and just say one word: steroids. How does that fit into your paradigm? What's your feeling on it? And then
So that's a terrific question, and probably when when Matt and I are going to do our EHR embedded trial, I think steroids will probably be the first candidate. Early data that we have shows that the change in probability in patients in observational cohorts, in patients who receive steroids, it's the same as patients who don't get corticosteroids. But I think that might be a timing issue. So I'm very interested. It's an interesting question, and may well explain some of that heterogeneity. So I think that's a low-hanging fruit in terms of what goes out of the door.
Thanks so much. That was wonderful. Really incredible science and really rigorous, and loved learning from your work. I'm curious, a conceptual distinction that you brought up early in the talk about prognostic enrichment versus predictive enrichment, and sort of the core sort of driving purpose is to do predictive enrichment and sort of understand this at a mechanistic level. I'm curious, I'd just love to hear you sort of think through whether there could be a lot of what you showed about the hyperinflammatory phenotype suggests in many ways it could be sort of reduced to this idea that it's severity of illness, or that you're actually doing a very good sort of like our tools in critical care to do prognostic enrichment has been limited, and what you've done is a very sophisticated and effective way of doing prognostic enrichment, perhaps instead of predictive enrichment. So I'm just curious how you'd respond to that.
Yeah, that's an outstanding question, and I now know who reviewer 2 is in almost all of them. I think that's a really outstanding question, and if I'm being extremely humble, I will say I don't know. And you're absolutely right. It could be just a really fancy prognostic enrichment, but what we have shown is that it provides prognostic information beyond Apache and SOFA, so that's a win. But really, it's very difficult to answer that question unless the NIH will fund some of the proposals that I'm trying to do, which is to have biology-embedded phase 2 trials. And so whilst the machine learning model that we built for clinical data is great, I don't think we can answer these mechanistic questions. And so the idea would be to use these point-of-care assays to collect deep biological samples, introduce an intervention, and then see how that changes the signature and or other underlying biological features. And I think that's the way to answer that question.
Hillary,
Oh, hi, Hillary.
I'll repeat and just repeat her question to the audience. Repeat her question.
Look at some of the interventional trials that you retrospect.
So just for the audience at Zoom, Dr. Faust was asking, is there a way to interrogate, correct me if I'm wrong, interrogate the trials that we've already looked at to see whether we can observe changes in phenotype classification and whether it gives us an idea about how quickly we should intervene in these patients?
Yes.
That change. And whether the therapies are directly implicated in changing of class. So that's a really good question. Unfortunately, in none of these trials have we found sufficient data that's been collected temporally that is able to answer that question in a way that we would find satisfying. The problem has been that the competing risk of death is another big problem, because these hyper patients die very quickly. And so a lot of the trials that we've looked at have collected data day 0, day 2, day 4, day 7. And by then, by day 2, about 30% of the patients have already died that do die. So it's been a real challenge. And I think to answer those questions, again, I seem to be deferring it to the fact that I think we really need to set up infrastructure to study this prospectively. The Panther trial is attempting to do that. And I think that that's going to be one of the ways to answer that question. What, however, we have looked at is that it does mediate, some of these interventions mediate a decrease in single proteins that we have measured over time, but it would be difficult to equate that to phenotype change. So I don't know is the answer, but it's a really good question. Thank you.
One last question.
Hi, fascinating talk. Thank you so much. I really appreciated the link to relooking at old therapies. My question has to do with going back to that messy slide. And within that slide, you had a lot of clinical phenotypes. So within your definition of hyper and hypo-inflammatory phenotypes, how does that intersect with clinical phenotypes that the patient is bringing to the table when they develop ARDS and sepsis, so such as like a frailty phenotype, or if they have underlying advanced organ dysfunction? Does it matter?
Oh, that's a really, really good question. And, you know, you can always invite me back and I can talk about that too. So just yesterday, I had the opportunity to present in the ICU data science lab, and we're studying exactly that. We're leveraging the ability to phenotype these patients at a scale and try and understand some of these epidemiological questions. And yes, absolutely, the clinical phenotypes do influence how you respond. We think the patient's underlying chronic organ dysfunction is an important characteristic. I think the genomic phenotypes are probably also important, and that's something that we're looking at. So these phenotypes are just the tip of the iceberg, right? Subsumed within them is much greater complexity. And once we sort of open our eyes to separating patients out into ways that are biologically meaningful, I think there will be added value to understanding what the patient's chronic health going into critical illnesses. And we're finding some really interesting things. These are still preliminary data, but we definitely think that if you have chronic renal failure, chronic liver disease, if you have hematological malignancies, you exposed to a pathogen, you tend more towards manifesting the hyperinflammatory phenotype. So there are definitely important implications for chronic health here.
And now the time that everybody's been waiting for, the drawing. And I will ask Pratik to do the drawing.
I have, I'm living one of my life dreams.
Spills.
And also, I'm so glad I didn't put my name in it now, because could you imagine if I'd pulled my own name out? I will let you.
Okay. Ahmed. Woo! One of our chief residents. Excellent. Just coming down. And we actually do have a piece of Dr. Jajour's artwork.
Thank you very much.
It's a reminder and memory. So,
oh, delighted. Thank you.
So congratulations, Ahmed. Congratulations. Thank you. All right. Thank you all for coming. Stay tuned for next month.